much for joining this session. We understand that we're the only thing standing between you and the toga party tonight, so we promise to give you a jackpot of information to set you on your way. So we are so grateful for all of you who are patient advocates for the efforts to support cancer patients and their families, as well as other patients who have chronic complex diseases. So thank you for what you do every day. I'm Patty Falconer. I'm a strategic advisor for Atlas and a healthcare consultant. And as a cancer survivor, a caregiver to my mom who had breast cancer, and the former executive director of cancer services at Stanford, I have a deep appreciation for how a cancer diagnosis affects patients and their loved ones. I want to introduce our panel today. So Shannon Lewis is the Senior Director of Client Operations for Atlas Health. I've collaborated with Shannon for the last 3 years, and among other things, she leads the Oregon Health Science University Patient Advocate Team. I'd like to introduce Michael Cross, Dr. Cross, who is the Senior Director of Client Success at Atlas Health, and he leads the implementation teams across the U.S. and the patient advocate teams for the University of Miami that we'll be discussing today. I had the great pleasure of working with Michael while we were both at Stanford. So we'll be hearing from our panelists very soon, but first we will review some slides to help frame our discussions. So, next slide. Today we will be presenting strategies to amplify the impact of your patient assistance program. As you know, exciting new breakthroughs in cancer research may not yet be translated to all individuals, and that some will be unable to access them. This will continue to lead to inequitable disease outcomes. For example, we know that disparities exist for individuals belonging to racial ethnic minorities, for women, for those residing in rural areas, and those that have low socioeconomic status, just to name a few. Our teams at University of Miami, Oregon Health and Science University, and Atlas took the initiative to study cancer health disparities, to assess outcomes, and identify opportunities to help more high-risk patients. After reviewing published studies, we learned that the lack of access to patient assistance programs likely continues to contribute to health disparities. Next slide. In fact, we know that social and economic factors may influence patient outcomes more than access to clinical care. And as we evaluate the success and impact of patient assistance programs, we need to intentionally include health disparity measures in addition to financial and productivity measures. Reviewing this list of sociodemographic data in this slide that is often readily available in electronic medical records or can be self-reported by patients can give you insight into unintentional access barriers for certain patient populations. For everyone in this room, our job is to cast a bright light on the sociodemographic characteristics of patients accessing patient assistance programs or those left behind. Next slide. So let's take a deeper dive into the power of the zip code. Let's review the University of Miami Sylvester Comprehensive Cancer Center Atlas Health study that we presented at the Oncology Nursing Society Annual Conference. I've summarized the key takeaways and best practices in these slides, and they're also available. You can check in with Atlas Booth 303 in the exhibit hall. University of Miami has a very diverse population where the majority of patients speak Spanish as their primary language. UHealth has a very robust patient distress screening process, which relies on social workers to address patient-reported health-related social needs, such as financial hardship. Like many health systems, staffing challenges made it difficult to respond quickly to patients financial needs. UHealth launched an enterprise patient assistance partnership with Atlas Health that included 6 bilingual patient advocates and an AI-powered predictive matching platform that was integrated with the electronic health record Epic. All patients treated in UHealth infusion centers were matched for patient assistance program eligibility. And then patient advocates helped patients enroll in charitable copay assistance foundations and drug manufacturer-sponsored patient assistance programs. And as a side note, these copay programs are not going to be affected by the 2,000 limit that we learned about relating to oral drugs. So often this is an unattended area of patient need. We then compared the patient population who received patient assistance to the population receiving treatment in the UHealth infusion centers. Since we did not have patient household income or household size available in the EMR, we designated each patient's zip code as high, medium, low, and low using the Social Vulnerability Index, which is publicly available by county, by state. The Social Vulnerability Index is a key measure which can help identify populations at increased risk for poor health. The Center for Disease Control, the CDC, uses the United States Census information to calculate Social Vulnerability Index per county based on 4 themes and 15 social factors that include socioeconomic status, household composition, disability, race, ethnicity, language, and housing or transportation status. A higher county Social Vulnerability Index score indicates greater social vulnerability, which is linked to key barriers affecting overall wellness. The most socially vulnerable U.S. counties have higher cancer mortality rates when compared to the least vulnerable ones. Next slide. Hold on, go back to the one before. Thank you. When we asked the question, does our financial advocacy partnership identify and help patients who are at the highest risk of financial toxicity, we learned that 96% of the patients who were matched as eligible for patient assistance resided in high and medium-high Social Vulnerability Index counties, which represents the most vulnerable populations. A recent study examining data at University of California, San Francisco's specialty pharmacy showed racial and ethnic and language disparities in access to patient assistance programs. Non-white patients and patients who spoke English as a second language were less likely to receive patient assistance when compared to white and English-speaking patients. In contrast, we learned that UHealth patients participating in patient assistance programs included a higher percent of patients at high risk for financial toxicity when compared to all patients treated in their infusion centers. 14% Black African American compared to 10%, 57% Hispanic Latino compared to 39%, and 61% female compared to 52% in the overall infusion center population. Commercially underinsured patients across all diagnoses represented the majority of patients helped. During the period of May 2022 to December 2023, UHealth received total awards of $2.9 million. And most importantly, as short-term outcome measures, we demonstrated that an enterprise, proactive patient assistance partnership can increase access to financial resources and reduce financial hardship for ethnically diverse and socially vulnerable patients to mitigate financial toxicity and reduce the risk of bad debt for the hospital system. Next slide. Let's review the key takeaways and the best practices from the Oregon Health and Science University Knight Comprehensive Cancer Center Atlas Health study that we presented at the America's Vitals America's Essential Hospitals program Vital 24 conference. Rural Americans make up at least 20% of the U.S. population and face inequities that result in worse healthcare compared to urban residents. The OHSU Knight Cancer Institute operates a multidisciplinary cancer program that catering to Oregon and Southwest Washington from its Portland-based campuses. OHSU hospitals serve a patient population with a large percentage of rural residents. 35% of Oregon and 14% of Washington's population reside in rural frontier communities. Rural cancer patients experience higher cost-related barriers to care due to health insurance coverage gaps, employment interruptions with lost wages, a higher out-of-pocket and travel cost compared to urban patients. For example, a recent study showed that 50% of rural cancer survivors faced financial burdens compared to their urban counterparts at 38%. So OHSU hospitals and Atlas Health launched an enterprise proactive patient assistance partnership, which, like University of Miami, included an AI-powered predictive matching platform and 4 remote patient advocates. All patients treated in OHSU infusion centers were matched to patient assistance program eligibility, and the advocates identified eligible patients and enrolled them again into charitable copay assistance foundations and drug manufacturer-sponsored patient assistance programs. While the majority of patients had a cancer diagnosis, all patients across the enterprise, regardless of diagnosis, benefited from this program partnership. Next slide. We then compared the patient population who received patient assistance to the patient population that was receiving treatment in OHU in hospital-based infusion centers. And we designated each patient's zip code as urban or rural frontier. The Oregon Office of Rural Health works closely with OHSU and defines rural as all geographic areas in 10 or more miles from a population center of 40,000 people or more. Frontier are remote counties defined as those with 6 or fewer people per square mile. When we asked the question, does our financial advocacy partnership identify and help patients who are at the highest risk of financial hardship, we learned that 29% of patients who were matched as eligible for patient assistance programs resided in rural communities, which represented the most vulnerable patients OHSU serves, when compared with 18% of all patients treated in OHSU hospital infusion centers. The Patient Assistance Program partnership notably and proportionally benefited rural communities by increasing patients' access to financial resources. We demonstrated that a patient assistance program partnership can be considered a care delivery intervention to help decrease health disparities and increase rural patients' access to care. This scenario may open up funding options within hospitals, such as moving financial assistance costs from clinical operations into other budgets like the community benefit or health equity budgets. During the first 3.5 months of this partnership, OHSU collected over $600,000 in awards, mitigating the risk of medical debt for patients and bad debt for OHSU. So let's learn more from our panelists about how these prestigious health systems achieved such notable results. Next slide. So Michael, I'm going to start with you, if that's all right. Great. So we've learned the University of Miami Health System, UHealth, is a large cancer program. And University of Miami UHealth recognized the need for better integration of financial advocacy into routine clinical practice. The Sylvester Comprehensive Cancer Center has a large cancer program with over 6,500 new analytic cases per year and over 350 faculty physicians. And UHealth assigned Atlas patient advocates demonstrated impressive results. So Michael, maybe you could share with us, how did the patient advocate team identify eligible patients and build a trusting relationship to accelerate patient assistance enrollment at scale, and what barriers did they face?
Thanks, Betty. I think ultimately, in really looking at scaling and adding efficiencies to the programs, it's important to break it into four main components, and those being specific to branding, communication, expertise, and technology. And so what I mean by that is specifically within branding is being an extension of the healthcare system. So as we know, patient advocates are in the weeds, working closely with the health system or the patients themselves. So ultimately, there's a lot of concern as well as skepticism, as we know, in the market right now in the healthcare industry, where patients are concerned with their personal identifying information being leaked, et cetera. So what we've done and where patient advocates have found success is identifying our advocates as extensions of the health system, meaning that they go in and they have, specific to Miami or whatever health system you're working with, have that email address. And then when reaching out for communications to those individuals, identifying yourself as an advocate of that health system. That really helps to build trust as well as ensure that the patients feel comfortable and secure within who they're communicating with. On top of that is really the communication, looking at the specific regions and locations in which you are interacting with. Specific to Miami, large Spanish-speaking demographic. So looking at that really holistically and saying, how can we better communicate with these patients? So hiring advocates who are bilingual or are able to speak multiple languages in the specific region and demographic location that you're supporting. Moving on to that as well is expertise. With the advancements of technology as well as changes to COVID, we've identified that people can be much more productive in a remote environment. And with that, also looking at sourcing nationwide searches. So talent, as we know, can be all over the US with expertise in various states and regions. So looking at being able to open up your talent pool to much more of a broader spectrum has been really, really successful as well. And then on top of that is technology. A lot of us take for granted the ability to be able to get in a car, access a computer, and it's really important to be cognizant that a majority of our patients may not have that same access. So looking at the technology that we use to be able to interact with those patients has really been beneficial. And within that technology, what I mean is specifically SMS messaging. Patients aren't able to get to the health system. It can be of a burden, gas prices, et cetera. Many patients may have to take a bus, right? So being able to have them access that technology on their smartphone, uploading forms and documents, and then signing via SMS has been really beneficial for us to not only expand to greater populations, but also being able to support patients who may actually be burdened or have a burden for health equity. So ultimately, I think it is really a combination of all four: the branding, making sure you're an extension of the health system, ensuring communication, bilingual, as well as being able to interact with the populations you're supporting. Then ultimately, the next would be moving on to ensuring that you have the expertise, the correct individuals to support that group and that hospital network, and then ultimately technology. Thank you, Patty.
Thank you, Michael. In our last session, if you attended with diversity and inclusion, speaking about the fact that it's more probable that individuals will have a cell phone, less so they'll have a desktop. So being able to create and facilitate communication and prompt response to be able to enroll the patient in a program, having the ability to use a technology that individual is more likely to have is really key. I think we also have learned through this session today and yesterday how important health literacy is. So being able to communicate in an individual's language creates not only that trust, but also creates that communication in a way that really resonates with the individual, allowing them to be able to access these programs. So, thank you. So Shannon, your turn. So the Oregon Health and Science University Knight Cancer Institute serves a catchment area, as we've learned, that includes a large rural population. And rural communities impacted by cancer urgently require financial advocacy to align with the care goals outlined by the National Cancer Institute. So patient advocates assigned to OHSU hospitals were very successful in increasing cancer and non-cancer diagnosed rural patients. They're increasing their access to patient assistance programs. So how did your OHSU assigned Atlas advocates expand access to patient assistance programs for rural patients so quickly, and what barriers did they face?
Thanks, Patty. Going into our partnership with OHSU, we knew that there were a lot of patients that already had outstanding balances and they could use our help. So we utilized a large volume of the drug manufacturer copay assistance programs, and that's because those programs have a very fast enrollment as well as reimbursement turnaround time generally, as well as typically generous retroactive review periods. And what I mean by that is some of these patients may have had dates of service 60 days ago, 90 days ago, where they're already suffering from that outstanding balance. And there are these programs out there that even prior to a patient's enrollment, there is this period where we can submit those payment requests and those patients can still receive reimbursement and be relieved from that. So that really helped us with our commercially insured population. Now for our Medicare population, especially those that don't have that supplemental coverage and they consistently have that 20% out of pocket, we really focused on those foundation grant programs, so HealthWell and PAN and Good Days and the like. And so we were able to receive this grant funding for those patients. It really helped make a significant dent, and we were able to reduce these patients' risk of bad debt within weeks because of the fast turnaround time. In terms of barriers, I can't say that we saw any significant barriers, but anytime you implement a new change, there's always a learning curve, right? And so a big part of that is having open collaboration with your health system partners. Every patient population is different. They engage differently, they communicate differently, and so it's so important to understand the patient population that you're dealing with. How do they best communicate and interact so that we can really provide that seamless experience to the patients.
Thank you, Shannon. Did you experience or did your team alert you to any barriers they faced?
I would say in rural communities, which I personally am from, I understand that, as Michael mentioned earlier, not everyone has access to a computer or a smartphone, and it can be very difficult. And I think that goes back to having the collaboration with your health system partners. If you have patients that you're having difficulty reaching, or they don't have the ability to sign documents electronically or provide their signature electronically, having your points of contact that you can work with that can continue to support that patient as well. They can meet with that patient on site so that the patient knows that they're fully supported, because we have the the same goal of just making sure that that patient can get the access that they need.
All right, one more question for you. Increasing patients' access to these programs is definitely a team effort. How did you effectively manage the team, the patient advocate team?
So I think that there are three primary components to that. And those would be resourcing, collaboration, and organization. Again, going into our partnership with OHSU, we knew a lot of patients needed our help, and so it was an all hands on deck effort. We had our patient advocates, managers, supervisors directly meeting with these patients, making sure that their needs were met. And because we had the ability to have so many hands and meeting with all of these patients, it allowed us to be able to make that impact very quickly, right? Like we could broaden our reach very fast. The second part of that, again, is collaboration, working so closely with your health system partners. And Michael touched on this earlier, it really shouldn't feel like a difference, right? Like we're serving these patients, we're representing our health system partner, and we are frequently meeting with them, discussing any challenges, just so everything is out in the open and we can make sure that we are providing the best possible service and care to these patients. And then the third thing is organization. I am a big fan and a big supporter of technology solutions because they do a lot of the heavy lifting for you, right? And who doesn't want that? But I know that there are a lot of people who maybe don't have access to that or they're not there yet. And so in those instances, I really think it's so important to make sure that you have a good organized process so that you're making sure that none of your patients are falling through the cracks. I know there's probably many people here today who have a manual system for managing their patients, and years ago I did too. I understand how how overwhelming it can be to utilize, in addition to your medical record system, Excel and Post-its and OneNote and flow sheets and everything else that you're using to manage your patients. It's not only overwhelming, but it's also, it opens up more opportunity for patients to fall through the cracks. So my advice would be that if you are using a manual system, that it's one source of truth, right? Try to limit all of the different sources that you have. And to go a step further, I would also say that it can help to organize your patients by what they need. So in a specific and a high level example, you could bucket your patients where your first bucket of patients are your patients who need that initial enrollment. They've never been enrolled, they have outstanding balances, and they really need your help. Your second bucket are your patients who you've gotten them enrolled or they're enrolled into a program, but they have some post-enrollment work they need help with, right? They have payment requests that need to be submitted for reimbursement. And then your third bucket are your patients who are already enrolled into a program, but maybe their expiration date is upcoming and it's time for that re-enrollment. Which, did anybody else feel that like chill when I said re-enrollment? Because you know that blizzard is right around the corner, right? So I really can't stress enough how important it is to have those processes in place, have open collaboration and communication, just making sure that you are able to give your patients everything that they need.
I'm glad you touched upon re-enrollment because I felt the chill a little bit, but it's, January is almost here, and often it's difficult to make sure we're on top of re-enrollment so that there's no break in coverage and support, so thank you for that. All right, Michael, I don't want you to feel lonely because I got a question for you now. How did you work with your health system partners to achieve these outstanding results and identify expansion opportunities to help more patients? Which program activities or materials were effective in reaching the intended audience?
I think it goes back to collaboration. That's a key word that we hear a lot, but specifically in working with health systems. Collaboration and then also the materials, educational materials that you may have. In addition to that, getting to know the health system partners. So I'll touch on the expansion in a little bit, but ultimately that collaboration, as we all know, working with a health system, there's a lot of different dyads within that organization, from pharmacy to clinical operations to oncology to revenue cycle and even technology, depending on the data that you need. And within those specific departments, there's a lot of nuances. There's a lot of key players and stakeholders, and those individuals change hands. So recommendation is really staying on top, having quarterly reviews, getting to know the health system partners as well as the individuals in those roles, keeping a roster of it, and making sure. So a prime example of that is within health systems, having those key stakeholders and getting their teams, not just the key stakeholders, but the teams. So it could be managers, supervisors, boots on the ground individuals. One thing that we run across frequently in our patient advocacy is communication confusion, in the sense that individuals at the front desk may not have any idea who you are and what you're supporting. So patients are making calls asking, hey, what do we, I'm working with XYZ program or specific advocate, and they say, I don't know who you are, it's a scam, right? And so that's a big concern as well. So staying on top of the individuals that you're working with in those organizations, whether it be that roster. One nice thing is having educational materials or flyers to be able to distribute. Who you are, what is your goal, what is your purpose, has been really, really beneficial across organizations, and allowing them to be able to trust you and your services. So I think in this case, communication is key, and letting them know, what you're there for, and having that, basically avoiding that communication breakdown. On top of that, another main component is really looking at expansion opportunities, and that comes with trust. If you don't have trust with a health system or the patients you're working with, then you're not going to get anywhere. And that takes time. And that takes time through showing proven results as well as building really an understanding of why you're there. And so one thing that has also been really beneficial is working with the health system to understand what are their goals. As we all know, organizations have different goals, a lot of it being financial at times, but really reducing barriers to access. So saying to the organization, the key stakeholders, what are your fiscal year 25 goals? What is it that you're looking to achieve? Many of them may say reducing, or improving the patient financial experience. Improving health equity could be another one, or really just increasing volumes. So getting into that health system, knowing who they are, and what makes them tick. And I think that's different for each hospital network that you work with, or system that you work with, or it be a clinic, facility, et cetera. So really knowing who the key stakeholders are, building that trust with them, and then reminding them of why you're there, but also asking them what are their goals. Because ultimately, if you're able to get a handle on that, you're going to have better ability to get what you need when you need that piece of data, right? Or you need that report. Showing them those results, and then, hey, I'm fortunate we can pick up the phone now. It wasn't always like that, where you can pick up the phone and contact a key stakeholder and get what you need. But that takes time, and that takes a lot of effort building trust. And so I think ultimately you hit the nail on the head with collaboration. It's not just with the patients. That is huge as well, but it's also with the health systems or facilities that you're working with.
When we think about a hospital or health system, an obvious place that patients are getting care that we can support is the infusion centers, and those are ambulatory infusion centers. But in these two examples of health systems at OHSU and University of Miami, once we started providing access to patient financial assistance programs in the infusion centers, we quickly learned through our health care partners that there were lots of other places within the system where patients were getting care who could benefit from access to these programs. In eye clinic, maybe you could speak a little bit about some of the things we uncovered.
Yeah, no, that's a really good point. Really asking them what is going on within there, and we've identified. So from eye institutes, right? ILEA is a huge opportunity for patients, and it's very expensive out of pocket. In addition, we've had hemophilia, so looking at expansion opportunities in hemophilia departments. And a lot of organizations may have team members already doing that work, but sometimes it's nuanced, right? They have other tasks on their plates, they have other responsibilities, and so patient advocacy isn't always the number one role of an individual within that network. So asking them, so we found, like I said, hemophilia, HIV is another one. So Cabenuva is an available drug. And sometimes it may not even be you asking, it may be them coming to you. So we found great opportunities outside of just infusion or oncology, specifically gastroenterology, endocrinology, ortho, GI as well. So there are programs out there, and it's getting to know the health system and asking them where they need support. Because ultimately, at the end of the day, they want the same thing, but unless you're communicating that there are programs available and working with them to gain their trust to support those programs, it may be an unturned stone.
Thank you. Well, I hope this session has given you some strategies to amplify the impact of your patient assistance programs, and hopefully that'll allow you to increase the number of patients you're able to support and elevate health equity. So I think we have some time for questions, if there's any from the audience. If not, the slides are available in the Swap Card app, from what I understand, or please drop by the Atlas app. We got it. So the question I heard was the work you're doing relating to prior authorization and how often that comes into play with the patient assistance, right? You want to take that, Shannon?
Yeah, I can speak to that. So again, it goes back to collaboration. I know that's the word, that's the buzzword, right? And every health system is going to operate a little bit differently. Typically what can happen is we will work very closely with the teams who are doing the prior authorizations, and that assistance may happen in tandem. So if say it's a payer that the health system has historically had some trouble with, especially if it's with a specific drug, we can go ahead and start that enrollment process with that patient. And so in the event that insurance doesn't cover, there's no opportunity to appeal that denial, we've already taken the necessary steps and have that safety net for that patient.
Thank you.
I'm a big fan of the auth and schedule model, coming from revenue cycle background. Ultimately, that helps reduce denials, right, from a rev cycle mindset. But in this case, it allows us more time to be able to support that patient, right? If the authorization is denied, looking at potential biosimilar. So then working specifically with that provider's team to say, hey, can we get this patient signed up if they're comfortable with a biosimilar? And then obviously saying, hey, we've identified a program that can be eligible. So that's been really beneficial, is having an ATS auth and schedule model. And that's something I actually push or try to push. It's not my shop anymore when I work with organizations, but try to educate them on why that model is really important. And it's easier said than done, obviously. You can't go into an organization and push something like that, but it has been beneficial in a lot of organizations.
Any other questions?
What was your name again? Tosh. So for those that may not have been able on the other side of the room to hear Tosh, Tosh was saying that knowing those key players in the organization, because there's different responsibilities, and if I'm hearing it correctly, pharmacy may have a dedicated team that may just not be the navigators or auth specialists, and it can be very complex across an organization. So really getting in there and knowing those key players across various dyads, as we mentioned earlier, is really important, because authorization, especially at organizations that Patty and I have worked at in the past, may have dedicated teams. Oncology may have their own specific authorization team separate from a scheduling team. So there's a lot of nuances within those workflows that you really need to be aware of to be able to best support the patient. And then again, back to the communication, sometimes when there's turnover, those people may not know who you are. So staying consistently on top of you, your services, and why you're there to support the organization and the patients combined.
Yeah, that was an excellent comment, and I completely agree. We, across our health system partners, we fully understand every health system, they work very differently. The setup is unique to every health system, and so a big thing that we do that I think is very valuable is, as we're initially building that partnership, we ask a ton of questions, and that's me. I'm the question asker, and that's how I introduce myself on these calls. So I will, we'll ask a million questions to make sure that we have the right people involved so that there's no communication gaps, right? The people who are doing the prior authorizations, they know who we are, we know who they are, and just making sure that we have that, again, that cohesive experience so that the patient has the best service possible. Great comment, thank you.
Great.
No, that's a great question. We're everywhere.
Yeah, we're across close to 40 health systems across the U.S. from the Midwest, Southeast, Northeast, so really all over, which makes my job fun with a lot of travel, but it's cool.
Today, we talked about two different NCI-designated comprehensive cancer center and health systems, one in Oregon and one in Florida. So that was a great question. Yeah.
So have you ever worked with UP Southwestern?
We have not.
They're an NCC and Cancer Center as well.
Good. Good to know. I'll connect with you offline. That'd be great. Awesome. Yes.
You talked about the rural and frontier communities, which is fascinating to me. I've never heard that from a frontier community. Do we work in any of the community oncology settings?
Patty, I don't know if you want to take this one.
So the answer is sort of a yes and a no. Yes, when they're connected to a hospital system. So just for those who couldn't hear Molly, she asked, is Atlas currently working with community oncology settings? So what you may have noticed across the country is academic medical centers and NCI-designated comprehensive cancer centers have built very robust cancer networks to provide care closer in communities where people work and live. And those kinds of practices, Molly, that are connected to larger hospitals as a health system are represented in our customer profile. We're open to working with all different kinds of providers, and it really has to do with scale and scope that provides, I think, the entree. So if there's anyone in particular you have in mind, we'd love to talk to you about it.
I'm just wondering if some of these community oncology hospitals refer to these larger practices so their patients can get the help they need.
We know that happens with very specialized treatments like bone marrow transplant and CAR T. That happens, right? But we also know that rural residing cancer patients and patients who recur, who finish treatment but then have recurrent disease, have to travel a long way to reach an academic medical center where some of these therapies are the only places where they're provided. So yes, the answer to your question is that these practices do refer, and they're likely referring to academic medical centers and these highly specialized cancer centers. Yeah.
So I'd just like to say I had the opportunity probably about 8 months ago to preview your demo on your software. And it made me feel like I was working with guys on each. I shared that with some of the staff this morning. I think it's extremely unique how you have the opportunity to hire your staff and your advocates to function in your health system, but provide the software that you have to understand to do that. So I was extremely impressed. Not had an opportunity to look at it and waiting, pushing for it to be implemented in our health system.
That's awesome. Thank you so much for saying that.
Can you recap? Just so people can hear it. I'm not sure everyone could hear.
Yeah, so if anyone couldn't hear, she had the opportunity to see our software and how it functions and just the ease that it really can have on a patient advocate's workflow. I know we're very proud of it, so we're really thankful for the feedback. Thank you.
Thank you.
What I think is really, really impactful is how many more patients we can touch, right? Coming from a health system for 15 plus years, health systems, I actually left. I left the provider side, which was a big jump, but I came because I believed in what we're doing. And it's a really neat product, but ultimately, it's a really great team that actually really cares about the patients. So you can see that in everything we do day to day, and Shannon starting as one of the first employees. It's really, really neat to see the impact. And we actually start every single QBR really with a patient story, as that's really the bread and butter of what we're doing. And you can start to see the health systems just tear up, whether it be, even if it's revenue cycle. We've even made revenue cycle folks cry, which has been really cool, telling those patient stories. So thank you for sharing that. It's really meaningful to us.
Tell the team what QBR means.
Oh, apologies. Quarterly business review. Thanks, Patty.
No acronym.
I know, right, Molly? I'm the worst today.
We have such a love-hate relationship with acronyms, right? So needed, but so complicated. So, any other questions before we conclude today? I guess it's time for you to get your toga on. Thank you very much.
Thank you, everyone.